Greetings. Welcome, Dave King, Penn Law class of 1982. Dave just stepped down after 13 years of CEO of LabCorp, the nation's largest medical testing company. And I'm grateful, Dave, for you joining us and helping me and others unravel some of the all that we hear about testing for COVID and how medical tests work and how you think we could streamline the process more. So thanks for joining us.
Thanks for having me.
Could we, before we get into the COVID specifics, tell us a bit about medical testing generally. As CEO of LabCorp, you oversaw a company that did millions of patient tests around the country every week. How much did you think about scientific issues? How much is about kind of logistics and delivery issues, privacy issues, because as we ramp up the tests for coronavirus, all of that is going to come into play. But tell us a bit about how medical testing on a very large scale works in this country.
Sure. So it's a big logistics and infrastructure and IT operation in addition to being a big testing operation. So on a typical day, we would see in the neighborhood of 450 to 500,000 patient specimens, doing an average of 3 tests per specimen. And those tests need to be drawn, they need to be prepared, they need to be brought to the laboratory, and then obviously they need to be run. So LabCorp has about 15,000 colleagues who draw blood. We have about 7,000 couriers. We have aircraft. We have a very large IT department. And then we have the in-lab personnel who actually run the test, as well as a very substantial amount of automation to simplify the process of preparing the samples.
To that point about logistics and, something I learned in talking with you in the past couple of years, when say somebody would do a test in Philadelphia or the suburbs of New York, the test is, and they do it, say, mid-afternoon, they might get the results the next day, but the test is not actually analyzed in a laboratory behind the storefront.
Correct. I mean, if you go to a draw station in Philadelphia, the likelihood is that your test is going to be performed in New Jersey, or it might be sent to North Carolina, or if it's a highly specialized endocrinology test, it'll go out to California for testing. So the network is distributed to optimize both speed and expertise.
Would you set the stage for us, Dave, with talking about we hear about 2 kinds of tests when we talk about COVID-19. There's the kind of diagnostic, or sometimes called PCR tests, which I guess, I'd ask you kind of what is that most useful for? And then we hear about serology tests, which are also becoming more important. So what are those the 2 basic kinds, and tell us a little bit about how those work?
They are. So the PCR test we use it to separate and amplify the strands of DNA and look for the virus. And so the PCR test will tell us whether the virus is in your nasal fluid or wherever the collection is from. And it will tell us whether you are presently infected. The serology test will tell us whether you have antibodies to the virus, which means that you've been exposed and your body has responded by creating these antibodies that eventually we'll be able to figure out whether they confer any sort of immunity from reinfection and what the duration of that immunity might be. Mm-hmm. So in a typical, for example, if you went and got vaccinated for the flu, your flu antibodies for that particular strand of flu would spike 24 to 48 hours later if we tested your antibodies. And the idea here is if you were exposed to coronavirus, your body would create antibodies to fight it, particularly those who have recovered without major symptoms.
Mm-hmm. But how accurate are those tests under current, as currently are there false positives, there false negatives, or is the testing relatively accurate both on the PCR and serology?
The PCR tests, now I should caveat this by saying there are a lot of tests out there right now. The FDA has been allowing tests to be brought to market under emergency use authorizations and also under emergency authorizations where the tests are actually put in the market before the FDA reviews the underlying reliability and so, or actually the methodology. So there are tests out there now that are not very accurate, and you can read about them in the newspaper. There are a lot of people offering home testing, and the FDA has issued warning letters, and so has the Federal Trade Commission about the testing scams. A well-validated test run by a responsible commercial laboratory or a responsible hospital or state public health laboratory, both on the PCR front and on the serology front, are highly reliable in terms of telling you what the test is designed to tell you, which is, are you infected with the virus? Do you have the antibodies? And ultimately, we'll be able to tell what level of antibodies you have in your blood.
How about, as we think about bringing people back to work, bringing students back to the law school and the university, another issue is how long, again, what is the current state of the art about how long does somebody have to wait if they're tested with a swab, PCR swab, and or the immunology? Is that a few hours? Is it a few days, somewhere in between?
So for the commercial laboratories, hospital laboratories, usually at the hospital same day. With the commercial laboratories, because of transportation, probably the next day. There are a number of instruments that we call point of care instruments or near patient instruments, where you can get tested and you can get an answer in somewhere between 15 minutes to an hour. Those are relatively low throughput, so you don't get the volume that a commercial laboratory can provide. And the reliability of point of care testing always is less reliable than a test that's going through a big commercial laboratory. Just a lot of variability in sample collection and accuracy, and even down to who's running the machines.
Yeah. So I guess, even when we get to more testing, and I'll ask you about that in a minute, we could still have different companies producing the tests and somewhat different reliability depending on which PCR test is being used.
I think generally the testing, as we scale up, reliability of the what I would call the reference lab or the hospital lab or the state public health lab testing will be high. I think it's no different from anything else. The near patient testing does have more variability, and that will always be the case. So there were some reports about one of the near patient instruments that for the PCR there was a range of incorrect results from 7 to 20%. That might be tolerable in a small population, but when you start talking about doing testing at scale, 7% error rates is obviously way higher than I think we would be willing to tolerate.
Yeah, for sure. It's going to be hard to make institutional decisions with that kind of error rate. So let me ask you the big question that we hear in the news and has been really for several weeks now. This is it accurate to say that nationally we did not have enough tests and we were not prepared? And if so, what are the factors that led to us taking so long to ramp up with rapid testing?
There's a long history behind this, going back to the Bush administration establishing pandemic preparedness, which then has not been well funded in succeeding administrations. So I should say, however, that nobody's ever going to be prepared for a pandemic of this magnitude. I mean, it is just, it's beyond anything that anybody could have comprehended. For example, the number of swabs that are being used in testing, and these are the nasopharyngeal swabs actually go through your nose and back into your throat, and the number of swabs is geometrically more than we would ever see used in a typical flu season.
And are those even made in the U.S.? Those, I mean, seems like such a low-tech device, but if there's a shortage of that, is that even manufactured here in the United States?
Yeah, so the two biggest swab manufacturers are in China and Italy, which obviously had their own coronavirus challenges. We validated a bunch of other different types of swabs, but it just, when we talk about there's not enough testing, we need to think about the whole supply chain. There's not enough instruments, there's not enough reagents, there's not enough swabs. I think that we got started slowly in terms of how contagious this pandemic was going to be. The typical patient with the flu infects somewhere between half and one other person, and typically a person with the flu tends to be symptomatic. People with coronavirus, at least at the outset, were infecting 3 other people, and there appear to be a large number of people who are infected but asymptomatic. So, so it's highly contagious. It's spread very rapidly, and we missed the opportunity to do the containment, and we went straight to mitigation. And of course, with mitigation, you would want to have a very steep ramp in testing. That said, the commercial laboratories started out doing several thousand a day, and I think now are doing in the neighborhood of total about 145,000 a day on average for April. So we are ramping. On the other hand, the studies say we need 500,000 to 700,000 a day to really do the kind of surveillance testing that we would like to do with the population. So there's plenty more work to be done.
Yeah, can you take us forward a bit into May? And clearly the numbers look better with each passing week, but is it going to be a kind of exponential curve? Is there enough testing capacity, or are there other, with the kind of initial shortages apparently somewhat addressed, are there concerns you have about our national capacity to do several 100,000 more every day?
My concern is around the matching of supply and demand. There is capacity in large laboratories today that's not being used. Part of the reason it's not being used is because many states, in an attempt to preserve personal protective equipment, which is required with the nasopharyngeal or the otopharyngeal swabs, have basically said, don't order testing unless the patient is acute. So we end up in a cycle where the testing isn't ordered. We say there's not enough tests, but there's unused capacity. So I think it's really important that there be some attention paid to, what is our goal with testing, particularly the PCR testing. The serology is blood-based, so it's a different proposition. But what is the goal with the testing, and how much do we really need per day, per week? And how can we optimize instruments that, there are 105 of the large Roche instruments in the United States. Many of them are in hospitals, they're in health systems that are not going to be running 3 shifts a day. So that is unused capacity. If they run one run of PCR testing a day, then 2/3 of the capacity of that instrument is unused. So we absolutely need to continue to ramp, but we also need to optimize the relationship between supply and demand.
Now, on the demand side, to follow up on that, Dave, do you think it's going to work best if the demand is large institutional health insurers like the University of Pennsylvania health system, or states or consortiums of states, or the national government? Or it does seem to be, do we want to centralize demand nationally, regionally, rely on big employers? What's your sense what would best match, in your view, the supply and demand?
My sense is that the federal government basically has put out a testing plan yesterday that essentially asked each of the states to come up with a plan. My hope is that we'll see the states working more regionally. So New York, New Jersey, Connecticut, Pennsylvania have already talked about doing a regional plan. You would hope Washington, D.C., Maryland, Virginia, West Virginia would do a regional plan. That would be extremely helpful to the laboratory community in trying to figure out how to allocate resources. Because as you pointed out earlier, the tests that you get drawn in Philadelphia may end up being performed in Pennsylvania. It may end up being performed in New Jersey. It may be performed in North Carolina. And so the demand may not be in a particular state, but if we approach it on a regional basis and work together, the laboratory community will be able to do a better job of the demand meeting the supply.
Mm-hmm. Well, thank you. That really helps me understand some of the issues, and I'm sure others who are watching this. Could I ask you to speak, Dave, more broadly about your time at LabCorp and kind of the role of medical diagnostic testing, I think, which has become a bigger part of our health system. It's a relatively efficient or low cost part of our health system compared to intensive in-hospital care. And can you speak about how a national testing company like LabCorp or other companies that compete with LabCorp fit into our health system? How have they grown over the time that you spent as CEO? And what are some of the things that you kind of discovered about our health system and insurance system through your time at LabCorp?
Sure. We in the industry always say that diagnostics represent 3% of the healthcare spend and inform about 70% of healthcare decisions. So the clinical diagnostics is a absolutely essential part of our healthcare system. I think for years, the value of testing has probably been underappreciated, but along comes a good pandemic and everybody realizes how important it is to, the laboratory as the front line of diagnosis, triaging patients and, appropriate treatment and care. I think that the laboratory is on the cutting edge scientifically. You talk about PCR testing that was developed, really came to fore during the HIV crisis because PCR was used to identify the virus, and then we were able to move to resistance testing and viral loads and turn HIV into a much more manageable disease. The laboratory industries developed companion diagnostics going all the way back to Herceptin, and there are over 100 companion diagnostics on the market now, and there are, I think, 40 or 50, basically all but one or two of the major drugs that were approved by the FDA last year either had a companion diagnostic or were targeted at specific biomarkers, like the immuno-oncology drugs. So the laboratory industry is essential and fundamental, and the average encounter price, for example, for a large commercial laboratory with an insured patient is probably less than $50. So we're a great value, and I think laboratory medicine will continue to be essential as we think about how to move the healthcare system to more preventive, more value-based, more optimal delivery of care.
And how many, what was your philosophy in terms to speaking of kind of efficiency and of course, although the doctor might have been involved remotely, I know a lot of your patients, wouldn't necessarily see a doctor as part of their going for a test. Did you have a philosophy like how close should a testing center be to the majority of patients? And did you, as you spread out geographically, how important was kind of convenience or from the patient point of view?
Well, we had actually requirements in our contracts with most of the big managed care plans about patient access points had to be within 5 miles of some percentage of their patients, some high percentage of their patients, other than in the kind of the most rural states. Access is critical. That's why we worked on retail access with Walgreens, and convenient patient access is vital. And the other thing that we spend a lot of time on, and I think all healthcare is spending a lot of time on, is mobile access, digital access, make an appointment, ease of check-in. And our process used to be a very paper-intensive process. You came to the service center with a requisition form from the doctor, your driver's license, your insurance card. We've automated all of that now. We have a kiosk where you check in. It remembers, it scans your driver's license and your insurance card. It remembers them for your next visit. And all of this is about making access convenient for patients and using tools and technology to be able to reduce the cost of the service to the patient and to the whole system.
Let me ask you a more, I have to ask the law dean's question about, you're a good example of how we like to say, somebody from this law school could end up anywhere outside, even, running a major medical company outside of the traditional practice of law. So how did you, did you think you would be a leader in the healthcare industry in the early 80s when you were here at the law school? And how did you end up in the CEO chair of the largest medical testing company in the country? I
always tell people that that Penn has been absolutely instrumental in my career. There's no question. First of all, being in law school, but particularly being at Penn, taught me how to think and how to think tenaciously. So, when I came to law school, I thought about a lot of things, but I didn't think tenaciously about a lot of things. And you have to think tenaciously. And I think of myself as sort of the ankle biting terrier, right? Once I get on an issue, I'm just going to keep after it until I feel that I have reached whatever the best solution is. That's what Penn taught me to do. And no, I never imagined myself as the CEO of a healthcare company, but as I practiced law, I learned that the combination of thinking tenaciously and having a point of view on topics, a lot of lawyers they want to tell their client, could be this, could be this, could be this, could be this. What do you want to do? I think it's really critical. And part of the reason for my progression in the course of my career was it could be this, it could be this, it could be this. But the highest likelihood of a best outcome is going to be over here on this one. And that to me is the difference between, that's the step, that's the jump that you have to be able to take to move from to move to the business side of an organization, because, we're taught in law school that all the facts matter, but we learn in business that we never have all the facts. And, we're taught in law school that we have to evaluate all the facts, and we're taught in business that we have to make decisions on imperfect information. And so I think being a tenacious thinker and having a point of view based on the information that you have, those are two critical components that help propel my career.
Mm-hmm. Well, I think that notion of decision-making under uncertainty is something we can we're all facing this time, but you're an example for me and our students and other alumni just of the different paths that our graduates can take into some really important and continually important healthcare and health policy matters. So I'm sure the issue of testing, and I didn't ask you about vaccines, but hopefully within 6 months or a year, we'll be able to have that discussion whenever that happens. And I really appreciate your joining me. You're always welcome to come speak at the law school when that becomes available, and be safe. And I look forward to talking again soon.
It's a pleasure. Thank you for having me, and be safe as well.